Our next category is in quality teaching winner, best of the best again, is The Secret is in the Chamber.
Welcome. The Chamber of Secrets has been opened. Experience is simply the name given to mistakes. In this film, I will share what I learned from the wrongs I did. Fluctuations in the anterior chamber depth intraoperatively during phaco emulsification can have serious implications. We are going to highlight two things in this film. Number one, the fluctuations in the antechamber depth intraoperatively can be the only sign suggesting of an impending grave complication. And number two, maintaining a constant chamber throughout, even in the presence of an open posterior capsule, can yield better outcomes. A stable chamber during the entire procedure is most desirable even during the course of any intraoperative events. However, momentary alterations in the antechamber depths during the procedure can indicate an underlying pathology such as posterior capsular tear. Let me take you through few cases. A middle-aged lady with a white cataract. As the intracameral anesthetic is being pushed in, there is a momentary deepening of the chamber and we see a pupil snap sign. Mind you, we are seeing at a stage where anterior capsule is not even touched. Well, it's easier to appreciate this phenomenon on a video review with multiple rewinds, but it can be easily missed during a live surgical event as it happens so sudden and transient. In this case, the sudden deepening of the antechamber was indicative of the occurrence of a posterior capsular tear, which was seen only when the nucleus was removed. And this was a case with a possible weak posterior capsule, maybe a case of a polar cataract, another case of a white mature cataract. As the OVD was being injected into the antechamber, there is a momentary feel of snap. The antechamber suddenly deepens. These changes are so momentary that one can miss them if we blink during the shot. My worst fear of an underlying posterior capsular tear was confirmed subsequently, and the case was salvaged by converting it to manual SICS. Now this is the third case of the emulsification being performed. There is a momentary fluctuation in the antechamber. This sign alone should warrant us about the possibility of an underlying posterior capsular tear. Phaco was abandoned, the case was converted, and as expected, a large underlying PC tear was staring at us. So these clippings taught me this. As surgeons, we need to be alert to this subtle sign that's a momentary deepening of the antechamber, as it indicates an underlying posterior capsular tear. Identifying this would help us to avert a major complication like a nucleus drop. So how do we suspect an underlying PC tear intraoperatively in an eye with an opaque cataract like these? These momentary fluctuations in the antechamber depth. The chamber deepens suddenly and comes back to its normal dimensions. Why does this happen? As the PC breaks, there is a communication with the vitreous cavity, hence the deepening of the chamber. Now moving on to the second concept. Now this is a white mature cataract undergoing phaco emulsification. As the last piece is being emulsified, I have an excellent red glow now, but I noticed something unusual. In a second, I realized that the situation is not great. A large PC tear is staring at me. What do I do now? As this was the last fragment, I thought I can emulsify this fragment as there was no vitreous prolapse at this stage. The followability of the fragment was good, and as the emulsification is being done, one eye of mine is fixed on the posterior capsule. The margins of the tear are irregular, but the edges are fluttering and not fixed, and the margins are not splayed, indicating the absence of a prolapsed vitreous. As the last bit of fragment is emulsified, I am thrilled and there is a momentary lapse of concentration. And in this brain fade, I just come out of the eye without doing anything. The real action happens now, so please don't blink. So did you see? It was like a bomb blast, except for the sound. So let me replay it. The phaco end piece comes out and the AC shallows. Now, as the AC shallows, we can see a ring appearing. Now this is the anti-hyaloid rupture happening and the vitreous prolapsing out. This was a costly mistake. If I had not allowed the antechamber to shallow and if I had injected dispersive OVD before coming out, the anterior hyaloid rupture and the vitreous prolapse could have been prevented. The rule of not allowing the chamber to shallow while withdrawing the infusion should always be followed. It is sacrosanct. Bimanual antivitrectomy is performed and a multi-piece hydrophobic IOL is placed with both the haptics in the sulcus and the optic pushed back behind the rhexis to achieve the optic capture. The second case, again please don't blink. I'm trying to hydropolish. There is a positive pressure. The patient moves his eyes just a bit and then this happens. Well, did you see what happened? Let me replay that. There is a small posterior capsular tear to begin with and then it enlarges, and after a second or two there is another ring developing. This is the anterior rupture and the vitreous prolapsing out. So this case teaches us that posterior capsular tear and the anterior rupture are two independent entities. There is a time gap between the posterior capsular tear and the anterior rupture. Had I been super alert, the anterior rupture could have been prevented possibly. Okay, let us do the right things now. Now this is a case of a posterior polar cataract. The posterior capsule is broken, but the chamber is never allowed to shallow. The eye is constantly replenished with OVD and the anterior rupture could be prevented and the IOL could be successfully placed in the bag. This is another case of a traumatic cataract with a pre-existing posterior capsular tear but an intact hyaloid. By injecting dispersive OVD before removing the irrigation, the chamber is never allowed to shallow. Anterior rupture could be prevented and the IOL again could be placed in the bag. So this case teaches us posterior capsular tear and anterior rupture are two independent entities. We can prevent the anterior rupture. The secret is in the antechamber. Maintaining the chamber equilibrium always is critical. Sudden deepening and shallowing of the chamber should be avoided. This is possible by using low infusion and low parameters. Use of dispersive OVD is critical. It acts like a barrier and it might prevent the forceful entry of fluid which could end up rupturing the anterior hyaloid. Well, many times the anterior rupture would happen immediately along with the posterior capsular tear, as in this case. We can clearly see the two tears, the posterior capsular tear and the anterior hyaloid tear. Even in such a situation, maintaining a stable anterior chamber will prevent the enlargement of the size of the posterior capsular tear and will help us eventually in implanting the IOL in the bag. So the secret is truly in the antechamber. Both sudden deepening and shallowing of the antechamber have great significance and consequences. So what did I learn? A calm and a tranquil antechamber ensures peace to the surgeon. Thank you.